Welcome to the APAP podcast. Today we're going to be talking about dissecting clinical trials and why we shouldn't just be lazy and skip to the conclusion section, which, in all honesty, I'm guilty of on occasion. Joining us today is Dr. Alain Eid, who graduated from St. Joseph's University Medical School in Lebanon in 1991. He did his medical school training in Paris, France, and completed his residency in internal medicine at St. John's Hospital in Detroit. His fellowship training in pulmonary and critical care medicine was done at Oklahoma University Medical Center. Dr. Eid was then appointed Associate Professor of Pulmonary and Critical Care Medicine from 1998 through 2004 at Oklahoma University. He's board certified in critical care, pulmonary, and sleep medicine. Dr. Eid has a special interest in lung cancer diagnosis and management. He was the founder and developer of the Lung Nodule Clinic and Lung Cancer Center at the VA of Oklahoma City, and here in Colorado Springs in 2 different hospital systems. But today, we're going to be talking to Dr. Eid about research, and this is where his medical passion lies and where he has vast experience. He was a principal investigator on many landmark trials in the areas of sepsis and ARDS. He has been published in a wide array of leading medical journals, including New England Journal of Medicine, CHEST, JAMA. He has been heavily involved in COPD, asthma, and CTEPH research here in Colorado Springs, and that is where he trapped me into doing research with him. Actually, it's been a great honor working with you on studies, and I've learned so much, but you were very transparent, asking me to get involved in research, making sure, do I really want to do this? Are you sure it's going to be really hard? And you were absolutely right. It was very difficult, but worth it, and I, again, have learned so much doing it. Especially with you, and I've learned so much, so I thought you would be perfect for this podcast. So thank you for agreeing for being on today.
Well, thank you for this honor. Your introduction means one thing. I'm old.
There's a lot more details.
When your introduction is very long, you're old.
Yes, yeah. The more details that are there,
exactly.
The longer you've been around.
Yes.
All right. So let's start with when you're reading a research article or a new study, whatever it might be, what's the first thing that you look at, and why is that important to you?
Well, let me start by saying that it is very important that healthcare providers look at articles, because when you go to medical school, they tell you, okay, you have a pulmonary embolism, you treat with anticoagulation. If you have sepsis, you give Levophed and you give fluids, but very few people bother to ask the question, why? Why do we do what we do? And if you really want to be a evidence-based physician, you have to look at the evidence. And this is where the house of cards comes tumbling down. Because when you look at the evidence, so many things that we do, are not backed up by any evidence, or the evidence is misunderstood. So, to answer your question, what is the first thing I look at? Well, okay, the first thing I look at is relevance to my practice, because we are inundated. There are a million medical journals out there. 95% of them are not relevant to my practice. So I just kind of cruise. One has to read what is relevant to your practice. I look at CHEST. I look at the New England. I look at the Society of Critical Care. So you have to be. It has to be relevant to your practice. Then I look at the conclusion, but I look at the conclusion knowing fully that I'm going to question the conclusion. So once I look at the conclusion, like, okay, sometimes it attracts my interest, sometimes it doesn't, and I skip it. Then I look at the most important thing that you have to look at, and unfortunately, it is in most journals, it is in fine print. I think it should be in very bold print. It's the methods. Because that is the question, really. What did they do? What was compared? What was studied? Because a lot of times we generalize the findings from a very specific finding to everybody. And I know we'll talk later about some examples of this, but it's extremely important to look at the method. Who was studied? Because studies have selection criteria. Not everybody is included in any research. So who was studied? Because that's going to be important. If my patient does not look like the patient population that was studied, maybe the conclusion will not apply to this particular patient. Then I look at, after I look at who was studied, like what patient population was studied, then I look at what was studied. And that is the major problem. And I run into a lot of arguments with a lot of colleagues because they are stuck on some preconceived notions. But when you look at the evidence, it looks like, okay, well, wait a minute, that's not what was studied. So what was studied? And again, we'll have some example later. And finally, look, I look at everything, but the most important thing is also the primary endpoint. Every study has to have, you are allowed one primary endpoint. Sometimes they are allowed two, but usually it's one endpoint. Now, there are secondary endpoints. There is a million of them. But remember, secondary endpoints, if you run enough secondary endpoint, and if you take a p of 0.05 as your cutoff, by sheer luck, you are going to bump into something, quote, significant. If you look at, pick whatever you want, the size of your large toe, and if you look at 100 illnesses, you are bound to find 5 of them that are somehow related to the size of your big toe, just by statistical likelihood. Okay, so there are liars, and statisticians. So the primary endpoint is the main endpoint. The others, you take it with a grain of salt. They should be hypothesis generators. They should be, oh, that's interesting, but they should not be the basis of what we do in clinical practice.
The study shouldn't be weighted around the secondary endpoints. And if they are, you feel like that's a red flag.
It's a major red flag. Actually, I don't even look. Secondary endpoints are like perks you get, but they should not be relied upon as a decision-making endpoint.
Okay. A lot of devil in the details, right?
The methods.
So are there any other red flags for you outside of the secondary endpoints being heavily weighted? Is there other things that you see that make you think, I need to take this entire study with a grain of salt?
Yes. The first red flag is the N, the number of patients studied. Now, if you're studying a rare disease, there's not much you can do. It's a rare disease. But if you're studying a very common disease, you have to be very careful with the N. Would you like me to give you an example that raised a lot of heat recently with the COVID?
Absolutely.
Yes? Okay.
Yes.
For example, there was a paper that looked at hydroxychloroquine for COVID. And the guy took 50 patients. 50 patients, gave them hydroxychloroquine. None of them died. He concluded that hydroxychloroquine saves lives because none of these 50 patients died. However, when you look at the death rate from COVID, it was 1% back then. So if you are looking at an event which likelihood is 1%, and you hit the roulette 50 times, there is a strong likelihood that you will not hit that event. That doesn't mean so zero is not zero in medicine. I did the confidence interval actually about the study. I ran the numbers and I found it to be 0 to 6%. So you can have no mortality on 50 patients and still be within the confidence interval of 0 to 6%. So the N is very important. The smaller the likelihood of the event, the larger the N. So if you look at a study and there's like 10, 12 patients, that means really nothing, okay? Number 2 is the selection of patient. Who was studied, okay? For example, if you do a study and most of these patients are 80 years or older, well, then if you have a patient who's 40 or 45, it might not have the same implications. So who was studied? Was the population very selective? I am going to take, for example, the DALI-RESP studies. The DALI-RESP studies took patients who have COPD, severe, with chronic bronchitis features and exacerbations. But for God's sake, that's very selective. So you cannot take that and then generalize that on all COPD patients, because what was studied is in severe, with exacerbation, and features of chronic bronchitis. So the result of the study apply to those patients. So if the selection is very tight, you cannot generalize. Flag number 3 is, was there a bias in the population? For example, if you take the COPD studies that looked at eosinophils, okay, we were studying, you and I were studying Nucala in patients with COPD. Oh, by the way, who had a lot of eosinophils. Well, are these really COPD or are they asthmatics? So you gotta look at this. I mean, drug companies are really good at doing this kind of stuff, that they insert in the study a selection bias that would favor the drug, and then they show that the drug is beneficial, but then they generalize the findings on pretty much everybody. So that red flag number 3. Red flag number 4 is vague language. Vague language. So if you're not like, wait a minute, patient with septic shock. Okay, well, what does that mean? If they don't specify what they mean by septic shock. So a patient who's been in the hospital who has sepsis from a identifiable source with a blood pressure of 90 or less for 2 hours despite fluid resuscitation, if it's just like septic shock, well, who do they include? We're not sure. Number 5. If the selection criteria is and it kind of is not like number 4, if it's a very generalized selection criteria, we can enroll everybody and anybody.
Was that the problem in the Zygris study?
No. The Zygris study, I happen to be an investigator in the Zygris study. The Zygris study, there was no problem with the Zygris study. The original Zygris study was amazing. It was fantastic. I participated in it. We were the second highest enrolling center in the world, actually. The problem with the Zygris study is that the second Zygris study, when the European FDA said, hey, prove it again. Prove your drug again. Well, what they did is they changed the methods. Instead of intervening within the first 12 hours in septic shock, which we all know that the sooner you intervene, the better the outcome, they decided to wait 12 hours, and in patients who failed resuscitation, then they randomized them. Well, you are selecting a different kind of, right there, that's selection bias. You are selecting a population that has already failed and is 12 hours. They insist on 12 hours. They are 12 hours through septic shock and still in shock. Well, the outcome's not going to be good here no matter what you do. Right. Septic shock is, if you ask me what is the main enemy in septic shock, I'd say time. Time to antibiotic, time to fluid resuscitation. Every time you look at a study that where time was the main component, you have good result. When you wait 12 hours, well, yeah, they failed. So it's amazing. Same drug, same patient population, same everything. One little change in the method, which is wait 12 hours versus immediately, took a drug that I swear, and I'll bet my bottom dollar that works, to a drug that was removed because it, quote, did not work.
Yeah, because then it didn't meet the endpoints in the secondary study.
Right? Correct.
Okay.
They
so
did not.
Talked about N. You talked a little bit about p-value. Are there other statistical measures that you think people commonly don't understand or misunderstand or should know better?
There was, I want to say 10 years ago, there was a paper that looked at the appropriateness of the statistical tests in the studies. They pulled 100 good studies and looked at the statistical tests that were used to analyze those studies and found, and those are statisticians, found that 70% of these did not use the correct statistical method. So, and I wish I can tell you more. I know a little statistics. I'm not such a good statistician to comment on those complex statistics. Usually, the more prestigious the journal is, the more likely that you're going to have the right statistics. But if it's an obscure journal or like a little paper, you would be surprised how many times people mess up the statistics.
Well, they
choose the wrong statistical method.
Yeah, I heard you the other day talking to, I think, a drug rep, and they were talking to you about the average, versus the mean. So Can you just elaborate on that? I mean, we know what average is, we know what mean is, but when you're looking at a study and they're giving you the average.
Well, we were looking at time to treatment for lung cancer from discovery to treatment. So let's say you have 100 patients or 50 patients, and you look from the time they call the office till the time they receive their first chemo dosage. If you look at the average, all you need is one guy who decided to go on a trip around the world before he gets chemo for his time to go from 15, 20 days to 200 days, and that person will cause the average to be much longer than it should be. Well, if you take the median, so how many people do that in half? Like which half, where is the cutoff line? At day 13 or at day 14 or at day 16? So if you let's say the median is 14, that means half of the patient got treated before 14 days. But all you need for the average to mess this up is an outlier. While the guy who waited 100 or 200, 300 days will still be on the other half and will not add to that median. But the average, that's different.
Okay.
That's an example.
Are there specific statistical data points that mean more to you than others, or ones that you're not as concerned about, but these are the ones that you definitely want to see in a robust study?
What you really need to see is the statistical method. It's the appropriate statistical method. You would also like to see the p to be low. I mean, a p of 0.045, yeah, it's less than 5, but a p of 0.001 means that this result can happen by chance in 1 in 1,000 times. So that gives it a lot more meaning for a result that can happen 1 in 1,000 times rather 1 in 20 times. So the p-value is important. The confidence interval also is important. So a tight confidence interval, let's say they take an FEV1 in a patient with COPD. Let's say the placebo group is an improvement in the FEV1 of 20 mils, while the intervention group is 150 mils. Okay, well, they're different. But how about the confidence interval? So the 20, if it's a tight confidence interval, you can say 10 to 30 versus 110 to 140. That's one thing. If the other, on the other hand, so that's very meaningful and solid. If the confidence interval is minus 50 to plus 80, and this one is plus 80 to 200, then the confidence interval will overlap a little bit, and you're not quite sure that there is difference between the groups. So a tight confidence interval, a low p-value, and a high n is the more of these you have, the better, the more solid the result, the more trustworthy.
When do you look at number needed to treat?
Oh, all the time. All the time. That is probably the most important number you look at, the number needed to treat. We're going to get to that.
Okay. All right. So next question I have for you is, actually, I think we covered all the main questions I had for you. So why don't we just go ahead and get into the studies?
Well, let's look at the number needed to treat.
Okay.
So the number needed to treat, the NNT is equal to 1 divided by the absolute difference between the groups. So if you have a group where the good outcome is 20%, and you give them a treatment and it goes to 40%, so that's a 20% difference. 1 divided by 20%, 1 divided by 0.2 is 5. So you need to treat 5 patients to have a good result. That is really good. Okay? The lower the number needs to treat, the better it is. But if you have a low difference, although it might be statistically significant and a solid result and all of that, for example, take aspirin for the prevention of a myocardial infarction. My understanding, and I know there was a recent study that showed that there's no benefit at all, but I'm not sure. Don't quote me on that. But let's say the mortality difference is 1% for the treated group and 0.5% for the untreated group. So if you take an aspirin a day, your likelihood of having an MI is 0.5. in the next 10 years. And if you do that, it's 1%. Okay? So that is 0.5%. The number needed to treat here is 200. So you need to take 200 people, all of them taking aspirin, for one of them do not have an MI. The 199 took aspirin for no good reason. Now, that doesn't mean you should not take aspirin. But if you say, hey, man, I don't want to take aspirin. I think I'm going to be one of the 199. It's not a major problem. It is not a major error. If you, let's say somebody has an ulcer, it's like, I don't want to take aspirin. I'll take my chances.
Right.
Okay. That applies actually to the lung screening. The lung screening.
Was it?
Yes, no doubt about it. Screening for lung cancer in the appropriate patient population, not in everybody, in the appropriate patient population, reduces your risk of mortality from lung cancer, I think at 3 years or 5 years, from 5% to 4%. That's a 20% reduction. 20% reduction. That's a lot. It's statistically significant, high-end, trustworthy statistics. Okay? If you take the national number of patients who get lung cancer per year, let's say it's about 400,000, I think, or something like that. Well, if you can reduce that, let's round the number for easy mathematics. Let's say it's 500,000, 500,000. If you can reduce that by 20%, you have saved 100,000 lives. Wow, that is amazing. So, at the macro level, at the level of the country, we should screen for lung cancer. But if at the individual level, I have a patient in my office and he's a candidate, and I tell him, hey, I'm gonna scan you, and if I do this for the next 3 years, once a year, I will reduce your likelihood of dying from lung cancer from 5% to 4%. Well, the patient might look at me and say, you kidding me? 1%? I don't want to. Now, if you're a high anxiety patient, absolutely, and we should recommend. I will be quoted as saying we should not screen for lung cancer. We should screen for lung cancer. However, if we explain to the patient what we're looking for and what to expect, and the patient said, you know what, doc, I'll take my chances. It is not the end of the world, because the number needed to treat in here is 100. You need to scan 100 patients to save one. So one might say, yeah, I know, I think I'm going to be one of the 99. I'll take my chances. Remember, you're going to do scans. It's going to come at a cost. It's going to come at some psychological burden. Because when you find something on a scan, why are you going to worry? I know that I have a mom, a wife, a sister, and a mother-in-law, all of whom had an abnormal mammogram. And I know how psychologically terrifying it is to have an abnormal screen, because, I mean, if for 20, 30 days you're not going to sleep. That is the same for lung cancer patients. You scan them, you find something, and they're going to be worried. Now, again, we should screen for lung cancer, but we need to understand what is it that we're doing, what are we providing, what kind of benefit we are offering this patient, and if the patient says, meh, I don't want to, that's not the end of the world.
Yeah. And understanding that number needed to treat, really helps, especially as a clinician, helps you understand that, one, you're going to get one patient out of the 100 that you screen if we're following this protocol. And with the occurrence of nodules also being so common, 1 in 4, right, you're more likely to find a nodule, go down that rabbit hole of surveillance, and it be benign. And so, yeah, it's very difficult in those cases. Back to like devil in the details as far as the methods. Do you want to go through ARDSNet? Because I know that can be...
Yes. So there's a lot of things. When you look at the research, first of all, you have the good research, but the implication of which should be taken with a grain of salt, like the ARDSNet, the lung screening trial, and then you have to understand what was studied. That we talked about the first point. What was studied? So let's take the ARDSNet trial. So the ARDSNet trial, and this is a point of contention between a very small minority like myself who believe that maybe we should not go as low on the tidal volumes, and 99% of other physicians who say always low tidal volume. So the ARDSNet trial if you look at the methods, and a lot of my colleagues, when I tell them read the methods, are puzzled. Like, oh, I did not know that. Because the ArtsNet trial tested not 6 versus 12 mils per kg. That's not what was tested. What was tested is 12 mils per kg, but if the plateau pressure is not 45, we increase the tidal volume until we hit a plateau of 45. Now, if you ask any therapist, any physician, any pulmonologist, a plateau of 45, they'll go, oh my God, that's blasphemy. That's like heresy. We know we don't even approach those numbers. But in the ARSNet trial, the 12 mils per kg group they increased the tidal volume until they reached 45 plateau. Now, in the 6 mils per kg group, they did 6 mils. They were allowed to increase that to 8 mils per kg if the patient showed low plateau pressure and they had flow starvation, like they were struggling a lot. So 6 and 12 were not compared. It's 6 with option to increase versus 12 with mandatory increase were compared. And then, 6 was better than 12. But we don't know if 6 was better than 12, if the option of 12 was to decrease. We don't know if 8 is better than 6. We don't know that 10 is not better than 6. We don't know any of that. So now we took this study and we generalized it in all patients with ARDS. Invariably, actually, heck, all patients without ARDS get 6 mils per kg, which I have found to be very difficult to apply in patients who have normal lungs, like neuro patients who are withdrawing from alcohol, patients who have no lung problems, and you give them those quote protective lung strategy, which is now descended from heaven as a guideline. And if you don't do that, oh my God, you're committing a major error. I don't buy it, because there is absolutely no proof that 6 is better than 12 in the non-ARDS. You see, so you have to look at what was studied and not just generalize everything.
It almost sounds like it was plateau pressure driven more than it really was.
Absolutely. Yeah. I mean, I have the study. I'll be happy to read the method for you.
Yeah.
Would you like me to read the method for you? So, in the group treated with traditional tidal volumes, the initial tidal volume was 12 mils per kg. This was subsequently reduced stepwise by 1 mil per kg if necessary to maintain the airway pressure, measured after 0.5 second of end inspiration plateau pressure level of less than 50. The minimal tidal volume, if the plateau pressure dropped below 45, the tidal volume was increased. Listen to this. I'm going to read this again. The minimum, if the plateau pressure dropped below 45, the tidal volume was increased in step of 1 mils per kg of predicted body weight until the plateau pressure was at least 45.
Yeah. Had they taken that part out of the method, you feel
the
like
methods. And if you look at it, here's the font. This is the method. The font is really itty bitty. They're little scribbles. As if they don't want you to read it.
All right. How about another study with some detail issues? I think I've heard you talk about the fluid resuscitation in sepsis.
The fluid yes. Actually, when I read the title, I was like, oh my God, this is great. We gonna know the answer. A lot of fluid or not a lot of fluid. So if you read the title, restriction of intravenous fluid in ICU patient with septic shock. You're like, oh my, maybe I should not be giving that much fluid. Great, let's see. A lot of fluid. I thought it's gonna be the holy grail about fluid administration. Then you read the conclusion. Among adult patients with septic shock in the ICU, intravenous fluid restriction did not result in fewer deaths at 90 days than standard intravenous fluid. It's like, oh, then we don't have to give a lot of fluid. But then you look at the methods, and you look at how much fluid was given in the fluid resuscitated or aggressive fluid versus restrictive fluid. On day one, the median for the restrictive fluid, at least they used the median, was 1.8 liters, and the standard was 2.7 liters. So it's 900 cc's. That was the difference between restrictive and aggressive. Not even a liter. So the aggressive fluid cases got less than a liter more on, I don't say on average, median. If you look at 5 days, at the 5 days total, 8.8 liters for the restrictive and 10.8 for the liberal fluid. So in 5 days, the only difference was 2 liters of IV fluid. Now one might think, well, okay, there's no difference, but I mean, really, do you expect a difference if the administration of fluid is less than a liter? Is this gonna really improve mortality? If it was 3, 4 liters, 5 liters, and maybe would have had different results. I don't know. Maybe it would have been bad, because we know that a lot of fluid in ARDS patients is bad. We know that. So although the statistics are good and everything is good, one would think like the intervention is the same. I mean, I can do the same exact study and show that giving 4 units of insulin versus 6 units of insulin doesn't make any difference. I can get the N, I can get the statistics, I can get everything, but then like, really, 4 units and 6 units of insulin?
Yeah.
It's the same thing. Of course, the fact that they're not different doesn't mean anything.
Right.
Clinically.
Or study design problem.
Yeah.
So we were talking about this the other day about relative risk, or, risk versus benefit. And you had brought up a 1960s article on anticoagulation therapy in pulmonary embolism. And, which is not the standards that we use now, but was just a great example of how statistics can lead you astray. Do you want to review that?
Yes. That's one more thing you look at when you look at his studies. Like, what an intervention? What is the risk benefit ratio of an intervention? And again, here, please. If you have to anticoagulate every patient with a PE, that should be anticoagulated.
Yes.
This is not the question, but sometimes we are faced with, what is the benefit of my treatment? What is the benefit? What is the risk benefit ratio? Okay. So the study I'm referring to, actually, it was the initial study that got heparin approved as a treatment for pulmonary embolism, because it was not, for a long time, wasn't before the 1950s, 60s.
Yeah.
If you had a PE, actually, first of all, it was not easy to diagnose a PE. Second, if you had a PE, they didn't know what to do until somebody said, oh, let's do some heparin. And lo and behold, turns out the N was small, 70 patients total, but they found that patients who received heparin had about 5% likelihood of a recurrence or some problem. Actually, 1 out of 20 had a problem. But patients who did not receive heparin, about 35% of them had a problem. Okay? No question about it. Anticoagulation is and should be the treatment for PE. The number needed to treat here is 1 in 7. So that's really low. You have to treat patients who have a pulmonary embolism, should be treated with anticoagulation unless there is some issue. Now, the problem we face sometimes is patients sometimes are at a higher hemorrhagic risk. They've just had a brain bleed, or a bleeding ulcer, or they have liver cirrhosis with a platelets of 20,000. They have a small PE. When you're like this, okay, if my treatment is more risky than no treatment, then you should not treat. A lot of doctors feel a lot of angst, like, oh my God, I need to do something. Sometimes, no, you don't. So, because let's go back to the study. 35% had bad outcome, but that's 65% who did just fine.
Mm-hmm.
We forget about these guys.
Of the untreated group.
The untreated group.
Right.
Yeah. And remember, this is the 1960s. So to diagnose a PE back then, it had to be a big PE. We're not talking about segmental, subsegmental here. So we don't even know. maybe we're so stuck in treating people with anticoagulation that sometimes you have a itty-bitty ditzel, nothing on the CT scan with the clean Doppler, low-risk patient. And what do? We put them on anticoagulation with all the inherent risk of anticoagulation. So one has to look at the risk-benefit ratio. Again, I'm not saying we should not anticoagulate pulmonary embolism. God forbid. No, we should. But if you can't, or if anticoagulating a patient is going to be more risky than leaving them alone, you should just leave them alone. So you need to know what are the benefits of your treatment before you start treatment, and what are the risks of your treatment before you start treatment. And then the only way you know that is from the papers. Because how else would I know what is my risk if I do not anticoagulate the patient with pulmonary embolism? I mean, if I don't read the paper, I won't know.
Right.
Because right now, if you ask anybody, it'd say, yeah, anticoagulate. And you say, why? Because we have to. But why? Because we have to.
Or even if you said, what's our risk if we don't? Nowadays, we're not doing studies like that, where we're going to withhold therapy from a patient. But there were no therapies, then. And so you could say, well, and that's a great example of flipping the number, right? They're just reporting 35% had bad outcomes if they weren't treated. But like you said, 65% weren't treated and did not have bad outcomes. So, kind of flipping those numbers, I think, are something you don't think of when you're reading a study a lot of the time. So looking at that risk benefit. Are there any other pieces of advice you would give to people maybe that are new to medicine, that are new to reading research articles, that you would give them advice on?
My biggest advice, and I give this advice to all my medical students and all my residents, ask why. Why? Why do I do what I do? Why do I give a thrombolytic for a patient in shock for PE? Why do I do that? I'll look at the paper, and then you're like, oh, it's very revealing when you look at the paper that created the reason why we have textbooks. Textbooks give you the conclusion, but that conclusion needs to be dissected and understood. So ask yourself, why do I do that? And then you actually, it makes medicine a lot more relaxing, because a lot of times, like, maybe I shouldn't do anything at all.
Well, I thank you so much for joining us today and donating your time and your knowledge around
My pleasure.
I really appreciate it. And to those of you that are listening, please subscribe to the podcast. It's the best way to support APAP. And please visit our website at pulmapp.com. Thank you.